Welcome to the Advanced Orthogonal Biomechanics class. Here we're going to be reviewing, on this initial slide, the bottom of the skull and the occipital condyles that articulate with the C1 vertebrae. You'll notice that they are a curved feature that is convex in shape, and it matches up with the concave superior C1 vertebrae. So looking at the key points, we have a biconvex surface that is kidney bean shaped, and the anterior portion of the condyles are pointed more medially than the posterior portions. When we look at the C1 vertebrae, the superior surface of C1 is concave to articulate with the convex condyles of the skull, also kidney bean shaped, also facing medially as the occipital condyles were. The inferior surface of the C1 vertebrae has flat or slightly concave surfaces that are oval in shape and also face slightly medially. When we look at the C2 vertebrae with the dens in the front, we have the superior surface of C2, which is convex, in order to articulate with the inferior surface of C1. There's a phrase in biomechanics called the instantaneous axis of rotation. Basically, it refers to the axis pivot point, an axis perpendicular to the plane of motion and passing through the joints at the instantaneous axis of rotation for the motion that exists in that joint. So in the following slides, we're going to look at how would the IAR exist inside the following joints. For instance, if you want to open a specific joint, how would you accomplish that? The following information can be found in these resources: Kirk Erickson's book, also the Biomechanics of the Cervical Spine with Normal Kinematics, as well as Biomechanics of the Spine by Michael Hickey. First of all, when we look at the side of the occiput and C1 relationship, we're looking down the x-axis, and this rotation occurring around the x-axis is a flexion and extension motion of the skull compared to the atlas. Typically, there's 20 to 30 degrees of this motion, with the IAR occurring at the condyles and the external osseous point being the mastoid. Flexion is only restricted by the anterior margin of the superior mass of the atlas against the base of the skull, and the extension is restricted by the tectorial membrane, which is the extension of the posterior longitudinal ligament. When we look at lateral flexion, we're observing this on the z-axis of rotation. So we're looking at that the z shoots straight out the front of the patient, and any lateral flexion is occurring around that z-axis. A maximum of 5 degrees of rotational misalignment can occur around the z-axis here, because there's a restriction of the ipsilateral alar ligament. So if you were looking at a patient who is demonstrating a 5-degree upper angle malposition, anything beyond 5 degrees would either be due to an alar ligament tear or genetic abnormalities. When you do flex the skull very hard one direction, it will encourage the atlas to slightly ease posterior on the side of flexion. When looking up the y-axis of the patient, there's also a 5-degree unilateral rotation capability of misalignment, but the restriction is by the cup-like articulations as well as the alar ligament. And typically, axis will misalign rotationally in the same direction as the atlas misalignment. When looking at the C1 and C2 vertebral correlation, once again we're looking on the x-axis, and there is 20 degrees of flexion and extension between these two joints with the IAR at the center of the dens. The flexion is restricted by the tectorial membrane as well as the transverse ligament, but the extension is restricted by the tectorial membrane and the anterior arch of the atlas. When looking at the C1 and C2 vertebrae for lateral flexion malposition or motion, we're looking down the z-axis. The axis spinous rotates away from the side of flexion. So for memorization for our procedure, remember that when you have a closed C1, C2 joint, the C2 spinous will typically rotate to the side opposite of the closed C1, C2 joint. When looking at the C1 and C2 rotational correlations, once again we're looking up the y-axis of rotation. there can be between 40 to 45 degrees of rotation between the C1 and C2 vertebrae, which comprises about 50% of cervical rotation. The IAR, previously thought to rotate around the dens, is actually rotating around the spinal cord. Contralateral vertebral artery occlusion will occur at 30 degrees, and the ipsilateral vertebral artery occlusion occurs at 45 degrees. Restricted motion is by the alar ligament on the opposite side. And note that the atlas and axis will typically rotate together as you rotate the cervical spine. So when looking at the biomechanics in total, what happens when we flex the head laterally to the right? You can observe that we close the occiput C1 joint on the side of flexion, which will compress the larger posterior mass of the atlas and encourage it to move or rotate more posteriorly. You can see that we opened the occiput C1 joint on the opposite side of lateral flexion, which allow more room for the larger posterior mass on that side to want to come through the open joint. C2 spinous will typically rotate away from the closed C1-C2 joint. So if we were to raise the right shoulder and therefore compress the C1-C2 joint, would that have the same effect on the C2 spinous, making it want to go away from the closed C1-C2 joint? Yes, it would. And this will become important when we look at our table placement influences of patient positioning in preparation for the adjustment. What would happen if we rotated the head to the right? The C2 spinous will rotate away from the side of head rotation. Or you could actually look at this as a C2 body rotating with head rotation. So we rotate the head to the right, C2 spinous goes to the left. As atlas stays with C2, the right side will typically go posterior and the left side will go anterior. Would passively rotating the left shoulder anterior and right shoulder posterior cause the same effect? Yes, it would. So our table placement protocol is going to use that passive influence to encourage a patient's malpositioned spinous to want to release. And this concludes the biomechanics review for the upper cervical spine.